Good morning and welcome to the Methodist DeBakey Heart and Vascular Center Grand Rounds. A few housekeeping items that I am told I have to discuss before we get started. When we ask questions, please use the microphones. The recording will be available for viewing later and will be transmitted on the YouTube channel. And for our viewers, if you want to submit a question, text DeBakey to 37607. We have some upcoming events. Cardiology for the Non-Cardiologist Conference will be held in May 17, and then the Cardiovascular Fellows Bootcamp in August 8. Today, it is a great pleasure to host Dr. Greg Michaud, who's coming to us from Boston. He is currently the Benheim Josephson Chair in Cardiology in Beth Israel Deaconess Hospital in Boston, and he's a professor at Harvard University. Greg has been a prominent figure in EP for many, many years. He was part of a glorious group in the Brigham in the early 2000s and late 90s, where he really made an impact in the field with very insightful contributions that were both mechanistically relevant to the diagnosis of SVTs and reentrant rhythms, as well as therapeutically relevant, is one of the examples of contributions that are mechanistically insightful and really show the cognitive aspect of EP. EP has become more lately a specialty of tissue destruction, and he actually embodies kind of the thoughtful aspect of EP. He then went to Vanderbilt, where he led a newly created division of EP, and then went back to Boston, where he's currently, like I said, directing the division of EP in Beth Israel. It's a pleasure to have you, Greg. So without further ado.
Thanks, Miguel. It was a pleasure to be here. And as I think your program is one of the ones when you invited me, I said, come in right away and I want to spend the day because Miguel is even more thoughtful. He's someone who's not going to give up on the mechanistic side of EP, which is still important to hold on to and teach, of course, because the next generation needs to learn it, not just how to turn on a button on the ablation catheter. So I'm going to give you sort of an EP perspective. We see patients a little, we don't see them for heart failure per se, but we see people for arrhythmias. And I thought this would be worth going over because we see people when they present with a ventricular tachycardia, and you're sort of looking at the patient and saying, well, why would that be? This is a young patient, or we don't really have a good diagnosis here. What is causing this VT? And you really need to think about that. And what I noticed was there were frequently patients who went for long periods of time with some diagnosis of, say, non-ischemic cardiomyopathy, but no further kind of delving into that diagnosis to figure out actually what they have. So I think, I'm going to give you an EP perspective on that. This is an interesting family. So this is sort of illustrative. This was a 27-year-old. She's a healthy woman. She came to us after a resuscitated sudden death on a treadmill in the gym. She had been visiting her family in the Boston area, suddenly collapsed on the treadmill. She was resuscitated, awakened without neurological sequelae. She wasn't intubated, anything. She had a troponin that popped up, not surprisingly. And her family history is also interesting. Her grandfather died at 52, unclear causes. They're a family from a Russian Orthodox family whose their father had immigrated to the US, and then the kids were born here. Her father had a diagnosis of cardiomyopathy for a few years, but otherwise undifferentiated. The brother, interestingly, had 2 bouts of myocarditis. He showed up in the ER with chest pain troponin elevations, and was given the diagnosis of just viral myocarditis. And a sister, 30, with AFib. So this is like an arrhythmia potpourri. We have atrial arrhythmias, ventricular arrhythmias, we have inflammatory disease, all in the same family. It's like, how could you put all this together? This was her initial rhythm. So it looked like a monomorphic probable VT here. It's a wide, complex rhythm. It degenerated. You can see here it degenerated to VF. So initially she was in VT, degenerated to VF with the paddles on, and then got shocked back to sinus rhythm. This was her EKG several days after the cardiac arrest. I didn't show the one immediately after because that often can look pretty abnormal anyway. But this is a pretty abnormal EKG. She's got this tall R wave. Could this represent posterior kind of infarct type pattern? She's got an axis that's very unusual, and T-wave inversions in multiple leads. Something very unusual about this EKG. She had a cardiac MRI, which is, what everyone in this situation should probably get in addition to echo. And she had, her ejection fraction was not normal. Again, this was several days after the cardiac arrest. However, she was not, her downtime was pretty minimal, and she awakened pretty quickly, so wouldn't expect necessarily her ejection fraction to be that low just from the arrest itself. And she had this diffuse ring-like subepicardial gadolinium enhancement, basal to mid. RV looked maybe mildly depressed and normal coronary origins. This is the pattern of LGE, sort of diffuse in almost every slice. You could see this subepicardial late gadolinium enhancement that even more apparent here inferiorly. This is the schematic of the enhancement. So this is 6 represents subepicardial. And you can see this sort of what we call a ring-like pattern. So it goes pretty much around almost the entire ventricle in this subepicardial pattern. Let's go back to her father. So her father had this diagnosis of non-ischemic cardiomyopathy. It had a coronary disease. He had an LAD stent several years before. His cardiomyopathy was diagnosed as sort of HFpEF, some shortness of breath with exertion, but preserved ejection fraction. He actually was the first one tested after his daughter's arrest, and he had desmoplakin genetic abnormality. Here's his EKG, so not normal, the wide QRS, lots of PVCs. But he'd never had syncope, never had VT, never had AFib. He also had an MRI pattern that was kind of similar. And if you go, again, this is what you get from usually an MRI reading is just non-ischemic cardiomyopathy, and then sometimes things like consistent with this or that, or it's hard to tell. And we're going to see that you can't always predict what the cause of the cardiomyopathy is by looking at patterns, although it's quite helpful to look at the patterns and try to figure that out. Father looks pretty similar in many slices to the daughter, this ring-like pattern of LGE. And here's his schematic of the LGE. Not quite as extensive as the daughter, but still pretty impressive. Now the brother. So she had a brother who showed up. Now he heard, okay, my father has a mutation. I had a couple spells at like pre-syncope. This was the brother who had recurrent myocarditis over the last several years. He showed up in the ER with chest pain and troponin elevations, and now was worried. He was given a sort of a benign diagnosis of just recurrent myocarditis. This was during one of those episodes of chest pain. There's no ischemia, but he's got sort of this funny right bundle pattern and this fractionated QRS in V2. his CMRI, so he had an MRI scan, and it's the same thing. So this kind of pattern of, I mean, you could like almost look at all of these MRIs, and they almost look, you would get them confused almost, family member to family member. Father's not quite as extensive, actually. Maybe that's why he got to an older age before things started happening. And these are the three familial LGE patterns. If you look at the daughter, the father, and the son, very similar. There's one other sibling who I didn't have access to her MRI. She lived in another state, but she had presented with AFib. So this is a very unlucky family. This is a 12.5% chance. Every sibling had it. So the father and all three kids had a DSP mutation. And presenting very differently, right? I mean, one of them had cardiac arrest. They're all around the same age. One of them presented with VT, and one just with recurrent myocarditis, and then eventually some syncopal spells that sounded kind of scary. So what are the genes associated with arrhythmogenic left ventricular cardiomyopathy? And this is where it gets kind of hard to tell from an MRI pattern, like what is what. But the most strongly associated with the left ventricular form of arrhythmogenic cardiomyopathy are the desmoplakin, is the desmoplakin mutation. And personally, I don't know what you think, Miguel, but that pattern of ring-like, it's not a signature for desmoplakin, but it is very common that when you see that, you'll find a desmoplakin mutation. I don't know what you feel about that, but we've seen just a number of those, that same pattern. Plakophilin is more right-sided dominant in the arrhythmogenic cardiomyopathy genes. And then there's a whole bunch. There's non-desmosonal genes. Filament C is important to know because it has a very high risk for sudden death. It's associated with dilated cardiomyopathy. These weren't dilated cardiomyopathies. And then skeletal muscle and cardiac involvement with a desmin mutation. The non-desmosomal genes, in addition, more ALV, left ventricular cardiomyopathy specific, lamin, titin, a transmembrane protein, which is, this is the one I think that's Newfoundland, specific for families in Newfoundland, phospholambin. We'll talk more about particularly lamin A in a minute, because that's a bad player. So here's a second case. So this is 2008, a 30-year-old woman. This isn't as dramatic, right? I mean, the first one, cardiac arrest, you're going to do everything. You're going to try to figure this out. But this is a woman who just came in with palpitations. She was a runner all through her life and was continuing to race a bit, races several times a year. She had done multiple marathons, and she would do weightlifting and running almost every single day for 1 to 2 hours. So really kind of addicted to exercise. But her family history in this case was pretty unremarkable. She had non-sustained VT on a Holter monitor, and this was her EKG. So, you've got a lot less going. You'd say, okay, palpitations. People can have non-sustained VT. It happens. You can have a normal heart and non-sustained VT. But this is a little concerning. You could say, oh, well, there's a persistent juvenile pattern. She's 30 years old. It doesn't really fit that all that well. There's some lots of PVCs, and if you looked at them, they actually were right ventricular in origin, not left ventricular in origin. So this T-wave inversion pattern is a little bit worrisome. It's the most common ECG diagnosis for the right ventricular cardiomyopathies. And, the echo is not the best thing to diagnose that because the right ventricle can sometimes be hard to see on echo. But it was mildly dilated. Maybe it was mildly depressed. You sometimes see that. I mean, if you have a very, very good echo reader, then perhaps you can trust it. But I mean, you sometimes see, minor abnormalities called on right ventricular, in the right ventricle with, but her CMR was suggestive of some fatty infiltrate and mildly depressed LV. And she got tested, and she has the plakophilin gene. So that's the one, if you remember back when we showed the lists of genes, that's the one associated with more right ventricular cardiomyopathy. So this was, this is a good pickup, I think. This wasn't someone that I picked up, but, she's a young woman. She's exercising like crazy. She has non-sustained VT, and someone dug in a little bit. There wasn't really a family history there that suggested it. Maybe everyone else was a slug in her family, I don't know, and maybe she just didn't have a lot of exercisers, and she happened to be a pretty strenuous exerciser. But this is important to know because with right ventricular cardiomyopathy, as you know, allowing her to continue to do this sort of exercise could be detrimental. It could cause further deterioration of her right ventricle, lead to more scar. She had eventually ended up having some VT in the future. She, I think, initially didn't listen and continued to exercise pretty strongly until she ended up with having some episodes of VT, and then eventually got a defibrillator and an ablation. So this was early on, though, being able to pick this up, and the genetics here were really important. So, I think that to say that doing a genetic test doesn't necessarily impact prognosis or diagnosis is probably not true. So for ARVC, plakophilin, like in this woman, is the most frequently mutated gene. Desmoplakin can be, but I'll show some slides that compare the two mutations and what you see, right versus left. Desmoplakin is not commonly associated with right ventricular only. It's really pretty unusual. It's really a right ventricular only cardiomyopathy gene. And these are a lot of the ones we already saw associated with left ventricular cardiomyopathy. They can be associated with right ventricular, but plakophilin, the desmosome genes are most common. This was an interesting study that looked at, this was a group at the Brigham who looked at desmoplakin versus PKP2, plakophilin-2 cardiomyopathy. You could call it left versus right. So when you have desmoplakin mutation, its LV predominant was exclusively present in 55% of patients with that mutation. So really almost completely just LV, no real RV involvement at all. That is not true for PKP2. You don't get LV without RV with plakophilin. So it's for the DSP, you can get LV and some RV involvement, but you don't see it the other way around with plakophilin. The other important thing that they picked up, and this was also, we saw this in this family that I just presented, myocarditis is associated with DSP mutations. And in this series, 15% had actually presented with episodes of myocarditis. You can also see probably much higher, like the father, when in his MRI, had evidence of inflammation on his MRI scan. And that inflammation is associated with LGE in almost all of them. So if they have these bouts of myocarditis, they're going to have LGE. And I think there's probably, that if we go back and just look at all the patients that were diagnosed with myocarditis, we said they have this subepicardial pattern, that this is viral. Probably a lot of these patients that we used to call viral myocarditis actually had some familial or a genetic basis for their cardiomyopathy. So, I think myocarditis, your antenna should go up a little bit if you have people showing up with myocarditis and really nothing else, particularly if their EKG looks abnormal, they have a family history. Particularly, you should think about potentially they have a genetic basis for those bouts of inflammation. Definitely associated with DSP, not with plakophilin though. In fact, in 4 of the DSP cases, they had been misdiagnosed initially as having sarcoid because the FDG PET lit up. So, we're sort of used to thinking FDG PET lights up, sarcoid, but it's not true. There's genetic, so for this one, genetic basis for myocardial inflammation. So the FDG PET is not specific for that at all. You still have to have a suspicion. The other important things to know were that the LVEF, less than 55%, was strongly associated with severe ventricular arrhythmias for DSP cases. But for plakophilin, it was RVEF. So for the predominant RV, makes sense, right? For the predominant RV gene mutation, it's the RV function that's more important and predicts the future. For the DSP cases, the LV predominant, it's the LVEF that's important. And if you look at that family, it kind of bears out because the father did not have LV dysfunction. He had the same gene mutation as his children. And he is, close to mid-60s, never had VT, never had an arrhythmia, had incidental coronary disease treated. But all of his kids are having actually arrhythmias. And the daughter had an EF of like 35%. So these genes do not express the same. I mean, I had a patient with Titan. This was one of the ones I had to ablate the right atrial appendage to get her AFib to stop, but she had a Titan mutation and presented with rate-related cardiomyopathy in her 70s. Mainly AFib was her problem. LV dysfunction was minimal with AFib and non-existent without it. But her son had a heart transplant. So there's variable expression of these genes, as you well know. The other thing is frequent PVCs. So this is the thing that keeps us up at night. Like we get sent patients with PVCs. Lots of people have PVCs. I mean, it's not uncommon. But if you have lots of PVCs, you should probably get some kind of workup. I have a lower threshold these days for doing an MRI scan in patients that are sent to me with frequent PVCs, just because, you can pick these kinds of abnormalities up. If an idiopathic, and probably a lot of these idiopathic PVCs we used to see actually probably have some form of cardiomyopathy. So these frequent PVCs associated with these gene mutations had a pretty high risk of subsequent ventricular arrhythmias. So it's important that when we see these patients with PVCs, they get some kind of workup and not just reassurance. This is the graphic form of what I've already said, that when you have a desmoplakin and RV dysfunction, your risk of sudden death, sustained VT, or appropriate ICD shock is pretty high compared to if your RV looks normal. Same thing for or the other way around, sorry, this is LV. And then RV for plakophilin. So when your RV is dysfunctional, your risk of sudden death, sustained VT, or appropriate ICD shock is much higher than if the RV looks preserved. This, we saw this pattern, again, the example in this particular paper by Katja Zeppenfeld, looking at patterns of LGE and sort of what the gene mutations are. You look at desmoplakin here, it's that same thing that I showed you, that ring-like subepicardial, and then, phospholaminin, filament C. But the important other ones are the antroseptal predominant ones, and that's lamin and titin. So they're a little different. They don't have that subepicardial ring-like structure. So if that's the case, if you see that on an MRI, you're probably not going to be looking at desmoplakin. The septal ones, lamin always involves the septum to some extent or another. Those patients progress to heart block at a very high rate. Desmoplakin, not so much. It's an epicardial phenomenon. And again, this looks like the patients I just showed you in the family. It's like almost identical, this ring-like subepicardial LGE. So this is, I wanted to point out that I think a lot of people have the impression that VT ablation in non-ischemic cardiomyopathy is not something that's very useful or successful, and I don't think that's the case. So I wanted to just point out that there are patients in whom VT ablation probably may be futile, depending on what stage they are in their disease, but that there's definitely a role for VT ablation in managing these patients, because some of these patients, they don't have heart failure. They're not ready for a heart transplant. And you've got to manage their ventricular arrhythmias. Getting shocks from a defibrillator is no fun. So this is an example of a patient, and I was really hoping this gene would be back by now, because I'm betting this is plakophilin. I'm sorry, desmoplakin. It's got a ring-like subepicardial LG enhancement, just like the ones I showed. And it went off like 2 or 3 weeks ago, and was almost ready. I thought it would be back by now, so I could tell you what the gene is, but I don't know. But this is you recognize this pattern. This looks almost identical to that family. So, it could be other genes, obviously, but I'm putting my money down on DSP. What we're able to do these days, the imaging is pretty good. This is a CT scan, which is sent to this company called inHeart and then reproduced. And you can see here, when you break it down into endocardial muscle, intramyocardial muscle, and then epicardial muscle, you can see the scar pattern. Here's that, if you want an illustration of what a ring-like pattern looks like, that's it, right? Here's this band of scar in the subepicardial layer right around wraps around the entire ventricle like this. This looks like something you'd say, well, how would you possibly, if you had VT, there's just too many circuits. But it turns out it's not really the case for some reason. Some of this is dense scar, and there's little tracks in it, and you can often figure out the predominant VTs and get rid of them, or at least can get them under much better control. But knowing this, from an EP standpoint, this is someone that we just went immediately to the epicardium. We didn't even bother mapping the endocardium. And I think some of the old myths about VT ablation doesn't work had to do with when we didn't really do epicardial access that much. And if you don't do epicardial access in a patient like this, you're not going to be successful. It's not endocardial. And you've got to, and if you're trying to reach the epicardium from the endocardium, that's very difficult. And Miguel has also, helped solve some of the problems we have with getting into the intramyocardial part by putting alcohol down venous branches, or you could even do it down arterial branches to try to reach difficult places. But the epicardial scar, actually they respond pretty well to ablation. So this is an example where you'd expect to have a pretty good result. And we have even more information from these special processing where this is now everything is put onto this, including you can see where the coronaries are, you can see where the major venous branches are, you can see the phrenic nerve right here, left and right phrenic nerves. So we can kind of get a very good idea when we're on the epicardial space, like I don't want to ablate here, because if I ablate right here with RF, I'm either going to create phrenic nerve injury, or I might have to try to do something fancy and move the phrenic nerve away so I can ablate there if it's a critical spot. Epicardial access, this is a lot of people have moved to doing this, although I don't always do it, but you can see this, you see this shadow of this bright rim here around the heart? That's after we infused CO2. So you can purposely perforate a small vessel and then infuse CO2. It creates a pillow. It's like a pillow of gas. And then when you put your needle into the epicardial space, you now have a buffer to get in. This makes it a lot safer. And it's, it's now going to the masses. So where epicardial access used to be the purview of academic centers, and only very few people kind of did it because they were the only ones that could do it safely, now I think a lot more people have access to that by these techniques that we're starting to use. This is a mapping catheter in the left atrial. Oops, can't get this to play. But once you're in the epicardial space, it's easy. It's just everything is right there. You just slide right over the muscle, and we can get these kind of maps here, which this is just in sinus rhythm. So even if you don't see VT, we can create a map that mimics a VT circuit and ablate it with pretty good success. And despite all of that ring-like band, there was really only kind of one area that seemed likely to be causing VT, and then when we saw VT, we could see the whole circuit. These electrograms just show you that this looks the entire time between two beats is covered with these electrograms, and that tells us that we're in the right spot. So if you look at all comers, ischemic, non-ischemic, what is the success of VT ablation? This is so kind of a registry looking at that. It's somewhere around a 30% recurrence at a year. But even among those who recur, some of them will be, the burden of their VT will be knocked down. I did a case the other day, which was this super cold catheter that can reach temperatures that are very, very cold. And he had VT like 3 days later. That's a failure. But he hasn't had it since. Like, it shut off after that, and he's done fine. He would be in the failed part of this curve because technically he had a recurrence. But he was having it every day, and now one episode. So I think, you could call that a failure, but I wouldn't call that a failure. The etiology of the non-ischemic cardiomyopathy is important. So again, the ones that we were talking about today, myocarditis, which although may be some of these may be genetic cardiomyopathies, like desmoplakin might be included in there. Dilated cardiomyopathy, ARVC, have much better success than some of the others. Lamin is the one that you have to watch out for. It is very difficult. It's a mutation that's seen pretty common in dilated cardiomyopathy in patients with VT. It's very arrhythmogenic. It involves the septum. So you're going to see heart block in a large percentage of these people. And it presents early. So it tends to be young people. And once you see it, the progression is pretty scary, actually. The VT results, this was a paper from when I was at the Brigham looking at all the Lamin patients that we had ablated. And the recurrence rate is very high. So to cure a patient with Lamin cardiomyopathy is not a goal when you're doing VT ablation. And most of these people, if you just follow these, they ended up with end-stage heart failure, transplant, death. I mean, the outcomes are not good. These patients are really, if they're candidates, need to go early and think early about heart transplant because, we can maybe control them for a little while with an ablation, but it's not a cure. And this is a progressive disease. So this is the one case where really we have the discussion, even though their LV function may not even be that bad, their heart failure may not be that bad, you start to have the conversation of transplant early on in these patients. And these are just sort of the, AV block, very high percentage patients when you follow them from first clinical contact to last follow-up, heart failure. I mean, it's one of the worst genetic cardiomyopathies you can have. It is the worst, probably. And then I'll try to make another point, which is that it's not uncommon that patients that show up with coronary disease and some sort of cardiomyopathy does not always equal ischemic cardiomyopathy. You could have coronary disease, and you could have what looks like an infarct, and that infarct is actually LGE from a genetic disease. It's not that uncommon, and mixed cardiomyopathies are not that uncommon. Or you have someone that comes with a outflow tract looking VT. It's an older patient, has history of hypertension, has coronary disease. That's not from an infarct. That's not where, and you look and there's no infarct there. So that's not an ischemic cardiomyopathy. That's something else, and that may be from longstanding hypertension, maybe genetic in younger people. But this is a good example. So this is a 76-year-old patient, history of hypertension, diabetes, paroxysmal AF. He's been treated with propafenone and had a VT arrest while on propafenone. An ICD place, he got put on amiodarone, and then came in with cholecystitis and had this particular VT. And this looks like, I mean, from our perspective, we look at these things and see, like, where is this coming from, right? And for us, this looks like this could be an inferior wall myocardial infarction scar. This is not that incompatible, except he's not had an inferior wall myocardial infarction. And his MRI looked like he may have had an inferior lateral myocardial infarction, but he has no significant coronary disease at all. And when you dig in, he's got a family history of cardiomyopathy. So this is, one of those examples where if he had hypertension and type 2 diabetes, if you hadn't dug in a little bit, you might have thought he just had an old infarct at some point. This is, okay, you could say, well, how does that change the management? Changes it somewhat, but also for his family, right? I mean, if you can identify a gene in this case, you can then, if the family wants to know, they have some marker to tell them, am I going to end up in the same boat? So I'll leave plenty of time for discussion here and give you some takeaway points. I think first, scar formation is clearly the hallmark of the arrhythmogenic forms of cardiomyopathy. If you don't have scar, you're not going to have monomorphic VT, unless it's idiopathic. So the reason you get monomorphic VT in an arrhythmogenic cardiomyopathy is the scar that's already formed there. And so really the gold standard there is to do a cardiac MRI. So in patients in whom you suspect this, and I showed you multiple examples of cases where you might not have thought about it, the MRI can be really useful. Like that young woman who's a runner and had just non-sustained VT and a funny-looking EKG. You might not have suspected that. To remember that these bouts of myocarditis, coming in a young person, otherwise unexplained, you really have to think about potentially a genetic cardiomyopathy. Particularly the DSP mutations are associated with that. And this is a point, I mean, I can't tell you how many times I make, every morning it happens in some presentation about patient has ischemic cardiomyopathy, and I was like, stop, okay, why do you say that? And in, I don't know, 10 to 20%, it's pretty clear that it's not an ischemic cardiomyopathy, it's something else. The scar patterns are pretty useful, potentially, in identifying the genotype. And, for Titan, in other words, if it's not involving, if you have a pattern that's not involving the septum, it's probably not a Titan mutation. You can be pretty sure of that. I think genetic testing is useful. We are doing it way more than we used to. We have a very low threshold for doing it now. And then finally, that patient that I showed with the epicardial VT ablation, went from daily episodes to nothing. I mean, that's, for patients who are getting shocks, that is a huge quality of life issue. And I think when you have a center like this, where epicardial access is trivial, where you have all the tools available to do VT ablation, obviously, this is a perfect place to send your patient with non-ischemic cardiomyopathy and needing of an ablation. But I think that's done too little out in general in the community because there's a kind of a myth that it doesn't work. And I think, yeah, okay, doesn't work, what does that mean? In some cases, knocking the burden down tremendously is a success, like the case I mentioned. And you can't, these graphs are hard to display, the actual success. The burden is much reduced. So I promised not to show a lot of electrograms. I couldn't help myself. I showed one slide with electrograms, more for Miguel, but I'd be happy to take questions and open up a discussion.
Start with a couple of questions.
Yeah.
So I'll start with a couple of questions. That was a great overview. So genetic testing, yes, it's helpful, but it's as frustrating as helpful. because we still get these patients that may have a clear phenotype, say someone with VT and LG on the MRI, and then you get genetic testing and you get 3 like near misses.
Yeah.
You know the phenotype is there, but the phenotype to genotype correlation is extremely frustrating to understand.
Yeah, but I think the other thing is over time that changes, right? As you get a bank of more of these VUSs and things that aren't clearly known as pathogens, and then there's more and more testing, we're going to start to be able to add new genes as pathogenetics. So I think I wouldn't discourage, again, if you don't have it doesn't change, in some cases it doesn't change the management all that much.
No,
but I still think it's important because we need to get a bank of
I'm not saying that I'm not trying to belittle it. It's just that sometimes, we don't have enough understanding of, and you showed a family with the same gene, and sure, there was some commonalities, but the clinical presentations were different.
Yeah.
So one of our colleagues, she's busy right now, but we're trying to get more insights by doing biopsies and trying to do gene expression analysis, because it's not just the gene that has a mutation, but how does it alter other gene expressions that could have electrophysiological impact. That's kind of interesting. It's kind of a fishing expedition, but it's one of the areas that we're interested in. And that leads to my second question. Do you see a role in biopsy? Because you mentioned PET scan as a confound, diagnosis. We think of it as diagnosis for sarcoid, but then it's confounding because you have overlapping
I think I guess when sarcoid particularly is in the mix, it can be useful, although you don't always get the right part of the piece of the myocardium to give you the answer. So, biopsy-like gene testing everything's complementary, and I would say yes. Yeah. I mean, obviously, if you have the gene, you have the gene. Do you need to do another biopsy? Yeah. Probably not, unless you're doing cool studies like you are. But I think I would say that nothing's perfect, and the more information, probably the better. But for things like this family, obviously, a biopsy was not really going to give you a whole lot of additional information. Again, if you want to, could you come up with an algorithm where you start with gene testing, that's negative, now you move to biopsy, you're looking, because sarcoid is like an imitator. Or you could call other things an imitator of sarcoid, I don't know, however you want to call it, but it's one of those things where, there were, in that one paper I showed, 4 cases were misdiagnosed as sarcoid, and they ended up having a DSP mutation. So it's, we're not there yet, but I think the more we get into, I think as a field, we need to get more information and start to move it forward. And part of that's just doing the testing, because the way these companies that are, develop, they get more and more information, and as they start to see the same thing pop up over and over again for a similar phenotype, then it becomes pathogenic.
So it's a challenge to classify findings, right? And our colleague advocates like repeat genetic testing every 3 years. But why? The genes haven't changed. But the knowledge and
new genes are identified.
What do you think we can do to modify this, the variable penetrance or expressivity of the same mutation? So you have someone that exercises a lot. And is it possible that during extreme exercising, there may be some subclinical, microvascular ischemia that may trigger some damage, and that leads to inflammation, and then the scar? Is that something that we can work with patients on modulating that?
I think for ARVC, the right ventricular predominant one, and it's probably this because the right ventricle is particularly susceptible to stress. And therefore will progress in terms of the LGE, or the fibrofatty infiltration. That we know, right? There's like animal evidence, the little mice that they make them run to get out of the water so they don't drown, and they run and run and run, and the ones with the mutation that do lots of exercise, clearly it affects. And there's some human data. You know in families where the athlete is the one that usually presents with, they're the clinical scenario. So I think it's less clear, but maybe that's something that needs to be worked out. It's less clear. The one family member in this desmoplakin family, she was the most athletic. I mean, she would run on the treadmill every day, and so there may be something there. I mean, and maybe it promotes inflammation. I don't know what the final common pathway is there, but it's hard to tell people not to exercise without data to say not to do it.
Yeah. My last question, and then I stop monopolizing this. The correlation between gene mutation finding and defibrillator. That is, to me, very challenging, because yes, you have a family member, you have one patient that has the mutation and has LGE and VT, of course you will implant a defibrillator, but the asymptomatic one.
Yeah, that's the tough one, right? I mean, that woman, if say the father knew he had this and the family knew that they had it, maybe the screening of that daughter would have identified a low ejection fraction earlier than her cardiac arrest. She was lucky. She just happened to be kind of in a place with defibrillators, and actually there was an EMT running next to her. I mean, that's the kind of thing you hear when you survive. But so she got resuscitated very quickly. But maybe she could have been identified earlier with genetic testing, and now the family got tested, and now you start to screen. She didn't have symptoms really going up to then. So it's hard. I think still the LV or RV function is an important part of that decision. But honestly, and you know this, it always comes down to discussion with, you end up talking to the family and saying, look, this is where we are. I had to have that conversation with the brother who had a syncopal spell, or near syncope, had never been identified to have VT, but had a pretty extensive LGE pattern. His EF was really pretty normal, though. He ended up wanting a defibrillator because he just watched his sister. So a lot of it is sort of discussion with the family, because we don't have the answer. We don't have a good way to risk stratify. And the father now is, he's much older he's 30 years older than his daughter and has never had a single episode of anything. So it is not easy. That's one thing, like almost, as you could tell by the way I asked the question, it's something we kind of dread in a way, that gets sent a group like that. But I've made peace with it more over time, and I feel like it's more a discussion between myself and the family. It's not me deciding you need a defibrillator. It's we're going to decide together. Here's the information. I can't tell you the answer for sure. And then, usually the discussion goes from there, but it's not your decision to make for that patient. I think that's the important thing to remember.
Thank you really for coming and stimulating an amazing discussion. For a non-electrophysiologist, I loved it. One is just a comment, and I'm fascinated by the progress of the science to help us in some patients that initially we thought, they were this. One is the evolution of genetics, your field, ability to map even in sinus rhythm from the epicardium, and at the same time, how do you use imaging, with amazing pictures of the newer CTs in addition to MRI to kind of put it together. I think it's fascinating. I have two questions for you. One, since obviously these are discovered retrospectively once you identify the gene in a family, is what's the penetrance or what's the genotype-phenotype correlation in patients who have a genotype but have completely negative, not only clinical, but also MRI findings? Meaning, do you have a gene in that family, because obviously you identified a proband, and how often, because that causes even more of a dilemma.
But that happens,
Yes, and how often does that happen? So that's one. Two, from a pathophysiological mechanism, why the predilection of scarring in the mid-level of the myocardium as opposed to epi or endo? Is there something like this that could help us maybe from a structural, functional point of view, and why inflammation, periodic inflammation, mimicking a myocarditis, as opposed to a gradual things that would happen over time and scarring occurs. I think it's fascinating.
Yeah, and it's a real myocarditis too. I mean, these are troponin elevations associated with chest pain, and it's a real thing. I mean, I'm an electrophysiologist. I'm pretty stupid about those kinds of things, but it's very, I mean, to go back to the other question, genotype, phenotype, I mean, even in this family, despite all of them having pretty significant MRI findings, the clinical presentations were so different. AFib in one, and a young, none of the others apparently have had AFib. So it affects the atrium too. It's not just a ventricular disease. Frequently, there's atrial involvement, which is less concerning because, you know, it's AFib. Okay, big deal. VT is a bigger deal. When people don't, so at least the way we've handled it is when we see patients, so say her brother had nothing. He had the gene, but nothing. He's expressing it differently. Without the LGE and a normal LV function, I wouldn't encourage him to have a defibrillator. I think it's the LGE part that is the marker. And in that study, it was pretty clear, like the LV function or RV function predicted pretty, now that may change over time. So it's not like you just say, see you later, we're done. I think you then would want to repeat that down the road. But unfortunately, with that DSP gene, that bouts of myocarditis are almost 100% associated with LGE. So that if they're having bouts of myocarditis, you're going to find LGE on their MRI. So the genotype phenotype thing, again, is it's a big mystery, and it's probably that there are other mutations that may make it worse. So you could have random mutations that are associated, if you have that genetic abnormality plus several other random mutations, or there's some environmental factors, things that we don't understand. Concerning the inflammation, I haven't really, I don't know if you have any additional information. I think we're kind of left in the dark there. Yeah, I don't know.
But that's laminae specific, the mid-septal,
yeah,
and then the desmopacking, or it could be subepicardial. So that is
why that happens.
Maybe some tension, the wall stress may be different.
Yeah, it's a great research question, unanswered research question.
Good morning. Thank you for the great presentation. I'm one of the advanced heart failure cardiologists here. Question regarding, two questions regarding underlying inflammation in these patients. A, do you know how many of them present with pericarditis? And is there knowledge about what is the prevalence of rheumatologic disorders in the inflammatory cardiomyopathies?
Yeah, at least in the papers that I've seen, there wasn't really much there in terms of like whole body inflammation. Myopericarditis it's sometimes difficult to separate the two, honestly. This gentleman, that pain that he was feeling probably was partly pericarditis. So I'm thinking, and it's subepicardial, so probably pericarditis is a common part of the myocarditis that you get. In terms of other things, now obviously some of these, desmoplakin's not just in the heart, so there's some other things that you could suspect, but I'm not aware of other rheumatologic issues. I mean, there's clear skeletal myopathies associated with some genetic abnormalities, but I don't know about rheumatologic abnormalities.
All right. So, thank you very much. Please conclude the discussion. Thank you for coming.
Yeah, thank you.